Good evening, everyone. Thank you for joining us this evening. We're just going to give it a minute as people filter in. So just bear with us for 1 minute and we'll get the lecture started. Thank you. Okay, we'll start this lecture. Thank you, everyone, for joining us this evening. We will be recording this lecture and sending it out to everyone who has registered. Tonight's virtual lecture will be given by Dr. Gohal. Dr. Gohal is a multi-fellowship trained orthopedic surgeon specializing in sports medicine injuries of the entire body. Additionally, he has subspecialized training in upper extremity surgery, shoulder, elbow, and wrist. He uses cutting-edge technology to treat sports-related injuries for both competitive athletes and for the general population. This includes everything from non-operative rehabilitation and specialized injections, platelet-rich plasma, stem cells, and bone marrow, aspirate, concentrate, to surgical procedures. He has experience working as an assistant team physician for professional athletes, including the Chicago Blackhawks and the Chicago Cubs. He has subspecialty training in shoulder replacement surgery as well as trauma surgery for fractures. Dr. Gohal is from Toronto, Canada, where he played competitive soccer up to the national level. His aim is to optimize recovery from sports injuries to allow athletes to return to sports as quickly and efficiently as possible. He believes in patient-centered care and customizes each treatment plan to meet the goals and expectations of each individual patient. In addition to performing sports medicine, surgery of the knee, shoulder, elbow, and hip, Dr. Gohal treats degenerative conditions such as shoulder arthritis, rotator cuff tears, knee meniscus tears, and cartilage injuries. Dr. Gohal received his medical education at the Michael C. DeGrout School of Medicine, which has been ranked among the top medical schools in the world. He subsequently completed a 5-year orthopedic surgical residency training at McMaster University, followed by an esteemed orthopedic sports medicine fellowship at Northwestern University in Chicago, Illinois. Dr. Gohal has published numerous book chapters and research papers with the focus on improving patient outcomes after surgery for sports injury. He has presented his work at national and international conferences and now acts as an expert reviewer for a number of top orthopedic journals. Dr. Gohal sees patients in our Manhattan office at 645 Madison Avenue in New York City and our Jersey City location at One Journal Square in Jersey City. This evening, Dr. Gohal will be discussing the management of shoulder pain. If you have any questions throughout the lecture, you can type them in the Q&A section at the bottom of your screen, and Dr. Gohal will answer them at the end of the presentation. With that, I turn over to you, Dr. Gohal, for this lecture on managing shoulder pain.
Thank you, John. Thanks for that introduction, and thank you everybody who's attending today. I hope you guys can each get something valuable out of this. And as John mentioned, if you have questions throughout the talk, you'll be able to ask them in the chat, and I'll be able to address them at the end of the talk. But as we go through, I'm just going to go through different pathologies associated with shoulder pain, some treatment associated with it, and we'll give some options to talk at the end. So we're going to go ahead and get started here. John, you can see my screen okay?
Yep, I can see everything.
All right, perfect. I didn't know John was going to give me that big introduction here, so we can kind of skip over my background. But like you said, I'm an orthopedic sports medicine surgeon. I work at Rothman, the Orthopedic Institute in Manhattan, both in Jersey City, and I'm assistant professor at the NYU School of Medicine. So we're associated with NYU as well. For sports medicine, I do the whole body. I work on everything from the head to the toe. And then for upper extremity, which is essentially your arm, I have general orthopedic training as well. So like you mentioned, I do shoulder arthroplasty or shoulder replacement, and I deal with arthritis of the arm, elbow, and wrist as well. So that's in addition to the sports training that I have. And I've trained in a few different institutions, as John mentioned, but I'm now in with Rothman in Manhattan, in New York, in New Jersey. So we'll just get right into it. This is kind of the outline I'm going to talk about. I'm going to teach you guys some basic shoulder anatomy first. Really only the stuff that's relevant to help you understand the different problems in the shoulder that I'm going to talk about. So without the anatomy, it would not really make sense when I talk about the different problems. So it'll help it all come together a little bit better. Then I'm going to talk about the treatment options for each one of those problems, and I'll give you some specific tips for how to rehab the shoulder well, and all in all, when you need to actually see a surgeon versus when you can treat this on your own or with maybe a physical therapist. So we'll get right into it. I have about 30 to 40 minutes of information. So hopefully you guys can stick through that, and then we'll answer questions at the end. Okay, so starting with some basic shoulder anatomy. So we're going to talk about the bones to start. So in your shoulder, you have the bony anatomy, you have the soft tissue anatomy. So for the bones, the main actual aspect of the shoulder joint is made up of the humeral head and the glenoid. And John, can you see my mouse here if I move around?
Yes.
Okay, perfect. So people can follow along. The humeral head is this round surface here, and the glenoid is this flatter surface here. It's like the ball and socket of the shoulder joint. The glenoid, or the socket of the shoulder joint, is attached to your shoulder blade, which is known as your scapula. This is important. This is the bone on which all your rotator cuff muscles sit, and we're going to talk about what those are in a minute as well. The humeral head, which is the ball of the shoulder joint, is attached to your arm, which is known as the humerus. So that makes up the main joint of the shoulder, but there's also a smaller joint a little bit higher above called your AC joint, or your acromioclavicular joint. So that's a joint that's joined by the acromion, the bone on the left, and your clavicle, or your collarbone, on the right. So those come together from a much smaller joint, and you can have pain or problems in that area as well. So we'll talk a little bit about the soft tissue structure, starting with the cartilage. So there are different types of cartilage. The main one that's important in the joint is your articular cartilage. So the cartilage that lines the joint surfaces. So you can see on the picture on the left, we've zoomed in on the socket or the glenoid, and we have the humerus on the right. That white structure is the articular cartilage that lines both sides of the joint and allows the shoulder to move smoothly when you move your arm around. Our cartilage can't be replaced, so it's extremely important that we keep this safe and we don't damage the cartilage. So when you get arthritis, what that essentially means is you're losing that cartilage in your joint, and over time that leads to pain and inflammation in the shoulder. Then there's also your labrum. So like I said, there's a few different types of cartilage. Labrum is a different type of cartilage, and this is a cartilage structure that surrounds the socket. So looking on the picture on the left again, this oval or pear-like structure is your glenoid, and that ring of cartilage around it is your labrum. That acts as a bumper or a stabilizing feature of a shoulder that prevents the humerus or the ball from popping out of the joint. So it's really important for stability of the shoulder. And then we can talk about the ligaments. Don't worry about all these big names on the actual picture. They're not important. All you got to really understand is that ligaments infer stability on the shoulder as well. So there's ligaments that help stabilize the AC joint that we talked about, the smaller joint above the shoulder. The main ones being the acromioclavicular ligament and the coracoclavicular ligament. So looking at the picture here, these CC ligaments are holding this collarbone down. So when you have a shoulder separation that some people hear of, which is different than a shoulder dislocation, a shoulder separation is when you dislocate the AC joint or the smaller joint, and that results in tearing of these ligaments, and the collarbone tends to pop up. And that's different than these ligaments down here. And the importance of these ligaments down here around the glenohumeral joint is they form what's called a joint capsule. So you can think of a joint capsule essentially like a balloon that surrounds the shoulder joint, and it keeps all the structures inside the joint inside, keeps the joint fluid inside, and it protects the structures that are inside the joint or intra-articular. And then there's the muscles and the tendons. So the difference between muscles and tendons, they're all really one continual structure, but the muscles join onto the bone via the tendons. So the end of the muscle, where it attached onto the bone, that's the tendon associated with it. So you have 4 rotator cuff muscles or tendons in the shoulder, and they're called the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So some of them are shown in the picture on the right. Your subscapularis is the one in the front of the shoulder that kind of attaches into the front of the bone of the humerus, and the other three are more in the back of the shoulder. And these are the muscles that allow you to move your shoulder in space and have range of motion of your shoulder. There's also the biceps tendon, which is important in shoulder pain as well. So there's two heads to the biceps, hence the word bi. There's a long head and there's a short head of the bicep. The long head of the bicep is the one that's important for shoulder pain because it actually goes into the shoulder through that joint capsule and attaches onto the top of the glenoid, the top of the socket of the shoulder. So sometimes if that tendon becomes inflamed, you feel it as shoulder pain, but it's actually your biceps. And we're going to talk more about that. So let's go into some of the common shoulder problems and we'll resort back to some of this anatomy we just mentioned. So we're going to start with the rotator cuff. So one thing you can present with is rotator cuff tendonitis. And what that means is inflammation of one or more of the rotator cuff tendons. So itis typically is a term to represent inflammation, tendonitis, inflammation of your tendons. Usually this is a chronic process that happens over time from repeated stress or overuse of the shoulder. And you'll notice that the pain can present in different parts of the shoulder depending which one of those rotator cuff tendons is involved. Because remember, we talked about that there's 4 of them. So what you'll notice is pain with certain movements. Typically with overhead movements, so anytime you lift your arm above the head, you get pain. With external rotation, so rotating your arm to the side can cause pain. But typically your actual motion itself is maintained. You're still able to lift your arm, but it causes pain. Often people find the pain is worse at night. And if you leave this untreated for a long time, then that inflammation can eventually worsen. It can lead to rotator cuff tears. This diagnosis is done clinically, something that we can diagnose based on examining your shoulder. We don't need an MRI to make this diagnosis. And there's a few different treatment options for this. We treat this without surgery. We don't do surgery on tendonitis. And the non-operative treatment options are physical therapy, oral anti-inflammatory medications like naproxen, Aleve, Advil, cortisone injections that can be done into the shoulder, and platelet-rich plasma or PRP injections. And I'm going to go over all these in a little more detail later on, but these are the general options that you have to treat tendonitis of the rotator cuff. So what's shoulder impingement? You may have heard this term before. And shoulder impingement essentially is when the rotator cuff gets pinched between the bones above the shoulder and the actual shoulder joint themselves. So the rotator cuff muscles, which you see on the picture on the left, they come and they attach on the lateral aspect or the outside aspect of the humeral head. But above, we have those bones we talked about, the acromion, the clavicle. So when you get impingement, it means that when you're lifting your shoulder up in space, those tendons are getting squished between this round ball and the hard bone above. And that can lead to the tendonitis that we just talked about. So typically in this scenario, you're going to have pain anytime you lift your arm overhead or when you abduct your arm to the side, like shown in the picture. And the treatment options are very similar. The non-operative treatment options, again, physical therapy, anti-inflammatories, injections like cortisone or PRP. In this case, there is a surgery we can do. It's called a subacromial decompression. And that's done arthroscopically, meaning we take a camera, put a camera inside the shoulder joint through small little 1 centimeter incisions, and we shave off the bottom of that acromion bone, this bone here, that's causing that impingement or pinching on the rotator cuff to essentially create more space for the rotator cuff to move. That would be an option that we would do if all the other non-operative treatments fail. And very rarely is this procedure done in isolation nowadays. Usually it'll be done in combination with the rotator cuff repair or some other surgical procedure that's necessary. So then we talk about rotator cuff tears. This is kind of a continuum that we've been looking at. So you can get shoulder impingement, that can lead to some inflammation or some tendonitis. If the tendonitis gets untreated, you can lead up with a rotator cuff tear. So tear is when you have a partial or complete thickness tear of one or more of your rotator cuff tendons. And this is when we have to get an MRI to diagnose. And the way this presents and the way that it feels actually depends on the way that it occurs. So there's 2 different types of rotator cuff tears. There's acute injuries, meaning something that happens suddenly or traumatically. You fall, you trip, you stretch your arm, or you get in a car accident. And then the degenerative rotator cuff tears, which happen over time just from repetitive use and essentially wear and tear. So the key difference is that with acute injuries, you typically will have a sudden loss of motion. So your shoulder was working totally fine, you fell, and all of a sudden you can't lift your shoulder anymore. That's concerning for an acute rotator cuff tear. Usually it's any motion that you'll feel the pain with, and you have decreased motion and strength. So remember we talked about tendonitis, usually you can still lift your arm over your head, but it hurts to do so. When you have a rotator cuff tear, you often can't lift your arm all the way up, or when you do, it causes a significant amount of pain. And you'll notice that there's a lot of weakness. You can't lift up heavy objects, you can't push against resistance. Once again, you can get night pain as well. A lot of times people just notice that rotator cuff pain is more significant at night. So it's one of the things that we'll ask about. Non-operative treatments are the same: physical therapy, anti-inflammatory injection. And then the surgery for this is an arthroscopic rotator cuff repair. I'm going to go into some detail about that later on, but essentially, again, we're putting the camera inside the shoulder joint. We're taking this part of the rotator cuff seen here that's torn, and we pull it back down, attach it onto the bone with bone anchors. Okay, and we'll talk about that a little more. Then we have shoulder dislocations. So shoulder dislocation is when the humeral head or the ball of the shoulder joint separates from the glenoid or the socket. And this can happen in multiple directions. The shoulder can pop out the front, which is an anterior shoulder dislocation, or it can pop out the back, which is a posterior shoulder dislocation. But either way, what you'll notice is there's a visible deformity to your shoulder. So if you look at the picture on the top right, there's a noticeable divot or gap in the shoulder because that humerus is not sitting where it's supposed to sit. Often during the dislocation, the arm goes numb. You get some numbness and tingling in the arm, and you're unable to move the arm at all. While your shoulder is dislocated, you have very little motion in the arm. So these are all signs that you've dislocated your shoulder, and usually requires a pretty high energy mechanism, a snowboarding fall or a car accident, something similar to that. In terms of treatment options, the first thing you have to do with the shoulder dislocation, you have to reduce it back into place. You can't leave the shoulder out of place for a long time because that can cause damage to the shoulder. So oftentimes people have to go to the emergency department, they get put under, or they get some freezing put in the joint, and the shoulder gets put back in place. After the dislocation is when we determine what the long-term treatment is, and that depends on the number of times you've dislocated the shoulder. If you dislocate the shoulder only one time, majority of times we're going to treat this non-operatively. I mean, we're going to have you in a sling for a couple of days, let the muscles relax and calm down, and then we're going to get you to see a physical therapist and work on strengthening those dynamic stabilizers of the shoulder. Those are your rotator cuff muscles, the periscapular muscles. The goal is to get the shoulder stabilized as much as possible and prevent any recurrent dislocations. And there's exceptions to that rule. There's certain people that will get surgery after a first dislocation, and I'm going to talk about those in a second. It's the ones who have certain risk factors. If you're one of those people who dislocates multiple times after the first time, then you're indicated to have a surgery for that problem. And that surgery we do is an arthroscopic labral repair. So what we call this is recurrent shoulder instability. If you think about that capsule I talked about, that balloon around the shoulder, the first time you dislocate your shoulder, you stretch that capsule out. So when that capsule is loose, if your shoulder doesn't become stable again through the physiotherapy, the shoulder tends to want to pop out again. You're at higher risk for a dislocation after your first one. Once that happens multiple times, then we talk about the labral repair. And I'm going to go into more detail about that. So the real problem with these shoulder dislocations is if you imagine the ball and socket joint like this, and we talked about that cartilage labrum that surrounds the socket here. So when you dislocate the shoulder at the front or the back, you hit that labrum on the way out, and that can cause tearing of your labrum. So you see that in this picture here, the labrum is now pulled off the glenoid and you have a tear there. When you lose that bumper, it's almost like you have a golf ball sitting on a golf tee, and now part of that golf tee is missing. The ball wants to fall off much more easier now, so you have less stability in the shoulder. There's some people that are higher risk of dislocating their shoulder again, and these are some of those particular patients that will have surgery after one single dislocation. Those are people aged less than 20. The younger you are, the higher risk you are for dislocation, just due to the natural laxity of the shoulder. Contact athletes, so those are going to be constantly putting stress on the shoulder, like a linebacker, where the shoulder is going to be constantly wanting to come out of place. They're a high risk as well, may decide to have a stabilization after a first dislocation. Or if you lose some bone when you have the initial dislocation. So when that ball comes out of the socket, when that impact happens, you can lose some bone on the glenoid side, or you can lose some bone on the humerus side. And when that bone's missing, you have a much higher risk of dislocating again, so often the surgery will be indicated. And the problem is you don't want to leave these dislocations alone, because every time you dislocate the shoulder, you cause more damage in the shoulder. You can injure the cartilage in the shoulder. Remember, we talked about the cartilage is very valuable. You can't get that back once it's lost. If there's you can break your bone, or called a fracture, if you cause repeated dislocations, and that requires a more involved surgery to fix. And you can also tear your rotator cuff, which is those tendons we talked about, and that would require surgery as well. So let's talk more about labrum tears. So the labrum, again, is that cartilage structure that surrounds the glenoid, or the oval-shaped socket of your shoulder joint. And that labrum can tear anywhere along its circumference. And depending on where it tears, actually has different presentations and different implications. So there's a few acronyms you might hear. So if the labrum tears at the top, we call that a slap tear, SLAP, and that's essentially just an acronym. What it means is superior labral tear from anterior to posterior. So when you tear the superior labrum, or the top of the labrum, here in the picture here, it's called a slap tear. And slap tear's main problem is it causes pain. When you get pain in the front of the shoulder, usually deep inside the joint, that can be indicative of a slap tear. And majority of the time, slap tears we treat with cortisone. We try cortisone injection, and a lot of times it causes that slap tear to settle down and people don't end up needing surgery. This is different than an anterior inferior labral tear, which is called a Bankart tear. You may have heard that term before. So when you tear the bottom of the front of the glenoid, it's called a Bankart lesion, and that's the one that you see when you have a shoulder dislocation. If your shoulder pops up the front, you can call it the Bankart lesion, and that's different than a slap tear because the Bankart lesion results in instability of the shoulder. So the shoulder wants to keep popping out. It can cause pain as well, but the real problem is it causes instability. Slap tears do not cause instability. A posterior labral tear, or tear at the back of the labrum, is when you dislocate the shoulder on the back. Very similar to a Bankart lesion, except now it's on the back of the shoulder. Pain is usually presenting in the back of the shoulder as well. Again, cortisone is an option for these labral tears, but for those ones that result in instability, we talk about surgery, doing an arthroscopic labral repair. Let's talk about biceps tendonitis. So I mentioned there's two heads of the bicep. The long head, or the one that goes into the shoulder joint, is the one we're going to focus on, the one that's red in that picture on the right. Typically for biceps tendonitis, which means inflammation of the biceps tendon, you get pain in the front of the shoulder. It can radiate down your bicep tendon anteriorly, and typically causes pain anytime you lift objects above shoulder height. So lifting up objects with the arm straight, the elbow extended, that causes bicep pain. You get some cramping of your bicep as well. The main treatment for this, one is rest or activity modification. So happens commonly in weightlifters or people who are constantly at the gym working out the biceps. So I'll tell them to avoid doing that for a little while to allow this to settle down. The oral anti-inflammatory medications can help as well. And then cortisone injections can be fairly effective for this problem as well, but we guide them specifically into the bicep tendon sheath. So it's different than for the rotator cuff, where you put the cortisone into the shoulder joint or into the subacromial space. Excuse me. Here, you can use an ultrasound or use direct palpation, put the injection in the front right into the bicep tendon. If these non-operative measures fail, which is the ones we typically start with, there's a surgical option for biceps, and it's called either a bicep tenotomy or a tenodesis. And those have two different meanings. So a tenotomy means we put a camera inside the shoulder joint, once again, done arthroscopically. Arthroscopic means camera in the joint. And we find that area of the bicep that's inflamed or damaged, and we cut it off from where it originates. The tenotomy means you just leave the bicep alone. You just cut it and you leave it. And there's actually studies have shown that you don't have any loss of your bicep strength or any function in your arm because you still have the other head. The short head bicep still intact. So the bicep functions fine with the tenotomy. The only problem that people find with the tenotomy is the bicep tends to retract down the arm because it's no longer connected up top, and you can get a cosmetic deformity where you get a little ball in the bicep. So to avoid that, there's an option called a tenodesis. A tenodesis means that you, once again, release the bicep from where it normally attaches, but you just attach it onto a new place in the bone where you, after removing some of that damaged tendon. So that helps get rid of the pain from the bicep tendon as well. Then we have adhesive capsulitis. So this is a frozen shoulder. And a frozen shoulder means when you lose motion in all planes because that joint capsule, that balloon around the capsule becomes thick. So for some rotator cuff tears, you only lose motion in specific planes, for example, forwards or maybe just external rotation. But if you lose motion in all planes, so forward, external rotation, internal rotation, that's typically a frozen shoulder. And a frozen shoulder can be primary, meaning it happened without a secondary cause, or it can be secondary, so due to another injury. Some common causes of primary frozen shoulder are inflammatory conditions. So people who are diabetic, people who have metabolic conditions like thyroid problems, they're more prone to get frozen shoulder. Secondary causes is because, let's say you injure your rotator cuff, anytime you move your shoulder now causes pain. So your shoulder tends to want to shut down to prevent that pain from happening. So it doesn't want you to move the shoulder. So it thickens and everything gets really stiff. You get pain at terminal ends of motion too. So when you have your arm maximally forward elevated or maximally rotated, that's where you feel the most. Majority of frozen shoulders that are not a cause of a secondary injury can get better with physical therapy, but you have to be patient with these. These can take a really, really long time. And the data is showing it can take up to 18 months for the frozen shoulder to resolve with physical therapy. A cortisone injection can help bring down the inflammation of that thickened capsule as well. It can help facilitate the physical therapy. And if you're one of those few who doesn't get the motion back after the non-operative management, then we can do another surgery called an arthroscopic capsular release. And what that means is camera inside the shoulder joint, we go in and release that thickened capsule all the way around to allow the shoulder to move a little more freely. And then we have shoulder arthritis. So this is different than a sports injury. This is a chronic injury that happens over time, typically in the older population. And what arthritis means is you have a loss of cartilage on the shoulder joint. So that articular cartilage that we talked about, when you lose that cartilage, you start to get progressive degeneration of the articular surfaces. You get little cysts in the bone, and then it becomes painful to move your shoulder because you're having bone-on-bone movement every time your shoulder moves. Again, this is something that happens over many years, not very suddenly. You'll notice the shoulder gets very stiff. You lose motion, but the motion is not lost due to a weakness in your rotator cuff. It's due to a mechanical block. So you'll notice that I'll try to lift your arm up and it's almost like it's stuck. You just can't move it because the bones hitting against each other. And typically you have pain in all motion. So for treat arthritis, we always start non-operative again. We start with oral anti-inflammatory medications, cortisone injections can help. But if it continues to bother you, get to the point where you're debilitated and you need surgery, you're looking at a shoulder replacement surgery. Now, I'll talk to you about a shoulder replacement surgery. There's two main types of shoulder replacements. There's an anatomic total shoulder replacement, and there's a reverse total shoulder replacement. And which one we do depends on the status of your rotator cuff. So if you look at the pictures on the right, the anatomic shoulder replacement, we cut off the ball, we replaced it with a ball, we cut out the socket, we replaced it with the socket. So the anatomy stays the same, it's maintained. Whereas on the right picture, that's a reverse. So you'll notice the ball is now on the socket side, the socket is now on the ball side. So we reverse the anatomy. And the idea behind the reversal is if you don't have a functional rotator cuff, the reverse total shoulder arthroplasty allows your deltoid to be the main function or the main muscle that functions to elevate your arm. Because if you did an anatomic replacement with an insufficient rotator cuff, then you wouldn't have motion in the shoulder and it would kind of be a waste. So that's why we do the reverse replacement in that case. And these are two options if the shoulder arthritis is debilitating. So let's talk about AC joint injury. So now we're outside the glenohumeral joint. We're back on the acromioclavicular joint, that small joint that's above the shoulder. And an AC joint injury or a shoulder separation is when you dislocate that AC joint. So there can be different varying severities of these, and it really depends on how many of those ligaments are injured. So on those pictures on the bottom, you see type 1, type 2, type 3, and it goes up even higher. And majority of these can be treated non-operatively. It's very uncommon that you have to have surgery for these, unless you have a very severe type 5 or type 6 injury. And if you have a situation, for example, in that picture on the top right, where the bone's sticking up so far, it's about to pop through the skin, that's a scenario where you may require surgery. But most of the time, it's a more minor version of this, where it's some slight elevation of the clavicle and collarbone, but you're having pain right above the AC joint right here. And we typically treat those in the acute setting, just with sling and rest, as there's some physical therapy to reactivate the shoulder. And we can do cortisone injections directly into the AC joint as well to bring down some inflammation. If you're one of those few who require surgery from this, there's two indications when you'll need it. One is when you have the picture on the top right. So it's a type 5 injury where the collarbone is about to stick out through the skin, that we have to treat and we will acutely repair that. So that's called an AC joint repair. If you're one of those who had a less severe injury, but over time the pain's just not going away, it's not getting better, now you have a chronic pain in the AC joint, then we can do an AC joint reconstruction in those cases. And I'm going to touch on cervical radiculopathy really quickly. This is something that can result in referred pain to your shoulder. So cervical radiculopathy, we're talking about the C-spine, so the neck. And there's a lot of nerves that come out of your neck and they go down the arm and innervate the different parts of your arm. So sometimes if you have a pinched nerve somewhere in your neck, you can actually feel it as a referred pain in your shoulder, but it's not actually from a problem in the shoulder itself. So the differences you'll notice here when it's a neck problem is the pain typically will radiate down the whole arm. You'll feel it right down to your fingers. You get some numbness and tingling in the hand, or what we call paresthesias. And there's typically no history of injury to your shoulder. So I don't remember ever injuring my shoulder, but this pain just came out of nowhere, and all of a sudden I'm feeling it in my whole arm. Typically, you still have good motion with the shoulder, and you still have good strength in the shoulder, unlike if you have a rotator cuff tear, where you're no longer able to lift your shoulder in space. Majority of these get better with physical therapy alone. They don't require any further surgical intervention. But there are also various targeted injections you can do with ultrasound guidance or X-ray guidance where you can actually target the inflammation of those nerves. In some certain circumstances, if you have a severe nerve impingement, spinal decompression surgery would be the surgical option for that. And there's fractures. I'm not going to go into much detail about this, but of course, a fracture can be a cause of pain in the shoulder. And fracture means a broken bone. They're synonymous. And the shoulder can break in a lot of different spots. You see the picture on the left here, it can break in various different patterns. And depending on the pattern that it breaks can dictate whether the patient needs surgery or whether they need a sling. I'm not going to go into details about this because this would be a whole talk on its own, different fractures. But typically what this will present as is you have a traumatic injury, so some high energy injury that resulted in the break. You have severe pain in the shoulder and a sudden inability to move the shoulder. If you have a shoulder fracture, it's very difficult to move the shoulder at all. You often notice a lot of bruising and swelling along the front of the shoulder as well. And that can be indicative that you should get an x-ray. So basically, if you're concerned that you have this problem, your first step is to go get an x-ray of the shoulder to make sure there's no fracture. Okay, so that's kind of the overview of a lot of different common shoulder problems. And now I'm going to talk a little bit more detail about those treatment options that we got into. So let's talk more about physical therapy. We say physical therapy over and over again, but what does that really mean? So what we say physical therapy, what we want you to do is you want to work on your rotator cuff muscles, those muscles we talked about, and the periscapular muscles, so all the muscles that attach around your shoulder blade that can help contribute to shoulder stability and shoulder movement. What we will do is if you come see me in the office, for instance, when I examine you, I'm going to find which areas are weak, which area need to be targeted. And the physical therapy prescription that I write for you has specific instructions on what exercises I want you to do and what areas of your shoulder need to be targeted. Because it's important to make sure that you're targeting the right things so that you can notice the gradual improvement in strength. If you have a motion problem, that's what we regain first. We don't do strengthening until you have your full motion back. The primary goal is to get full motion in the shoulder, and then followed by that, you can work on strengthening. A couple tips if you're doing some exercise on your own, because a lot of time people do home exercise programs in addition to the formal physical therapy. You want to warm up with about 5 to 10 minutes of low impact activity. So this is just walking, stationing your bike, anything that gets the blood flowing in your body. If you're going to be doing strengthening exercises, make sure you stretch before and after the strengthening, and don't ignore pain. It is common to have some discomfort, which is fine, but if you're having severe pain while you do these exercises, that's not something you should ignore. That's abnormal. That's something that you should get checked out and make sure that you're doing the right things. This here is a website that has some great shoulder exercises. So this is a conditioning program that was developed by the American Academy of Orthopedic Surgeons. This is a very renowned group of surgeons throughout the country who come together to make clinical practice guidelines. You can take a screenshot or write this website down, or if you just Google AAOS, rotator cuff shoulder conditioning program, like I have in the title at the top, this link will be the first one that comes up. It has a bunch of different exercises you can do to warm up. It has a bunch of different exercises you can do to target different parts of your shoulder. So if this is something you want, if your shoulder is not too severe, you want to try doing some exercise at home, this is a good option for you to check out. Or if you do a physical therapy session and then you want to do some home exercise on top of that, this is again a great program to check out as well. But if you're concerned that there's a major injury to your shoulder, you should definitely see a practitioner before you do this. So let's talk about the anti-inflammatory medications. There's a ton of these, hundreds and hundreds of these, but the main differentiator is over-the-counter medications, there's prescription medications. Some over-the-counter examples are Advil, ibuprofen, Motrin, Aleve. Some prescription examples are naproxen, diclofenac, meloxicam, and these prescription ones are essentially just stronger versions of the over-the-counter ones. And these are very low-risk medications. They have a very low side effect profile. They don't make dizzy. They don't make you dizzy. They don't cause any loss of consciousness or change of your drowsiness or anything like that, which is why we like them. You can function, have a normal day-to-day activities with these medications. And there's no addictive properties as well. So a lot of people are concerned with narcotics because it can have addictive properties, but the anti-inflammatories don't. The biggest side effect we see with these is some gastric irritation or some stomach pains. And in that case, we just tell people to either stop them or use a stomach protector to protect the lining at the same time. So cortisone injections. Cortisone is different from the NSAIDs or the non-steroidal anti-inflammatory because it's a steroidal anti-inflammatory medication. So this is a steroid that we put directly into the area of pathology that's causing you problems, and it bathes that area to prevent or to reduce inflammation. So it's a very strong, localized anti-inflammatory effect. It's not like a cortisone pill where you can get systemic effects of the steroid. It's very localized to the area where we insert it. Typically, it's pretty fast acting too. It takes about 5 or 6 days, and then you start to notice the effect of it. But the effect that it has varies depending on what the problem is, who the patient is. Everybody reacts a little bit differently to cortisone, and depending on the severity of your problem, you may get a full effect or may get partial effect. So it's important to talk to the doctor about that. Once again, very low risk of these, and it's minimally invasive. Of course, less invasive than surgery. So there's a lot of conditions that we'll recommend trying this first. And then platelet-rich plasma. So this is a different type of injection we can do where we draw blood from the arm and we put that blood into a centrifuge machine. So there's a machine on the side that's showing what it is, and it basically spins this blood around and it separates it into different components. And the component that we want is the platelet-rich plasma portion. So the plasma has these healing factors and growth factors. We then take that part isolated from the blood and inject it into the area where you're having a problem. So this initiates a strong inflammatory response and a healing response. It can be very effective for treating a number of different shoulder pathologies. What I always caution people is this is a newer intervention. It hasn't been around for as long as the cortisone or the other medications. So there's not as much evidence that supports it for different problems. And for that reason, it's not always covered by insurance. So a lot of times it's an out-of-pocket cost just because it doesn't have as much research behind it. So it's not our first go-to option. We'll typically try the things first for patient convenience. But it's always a great option if you want to try it out and can a lot of time help you avoid surgery. But when is surgery the answer? So when do you have to come see us in our blue pajamas here? And that's most often when non-operative treatment fails. So usually we give people about at least 6 to 12 weeks of non-operative treatment. Again, it varies depending on what the specific problem is. But when non-operative surgery treatment fails, then surgery is usually the next option for you. But there's also specific conditions where you should go to surgery right away, and we don't try the non-operative options first. And it's really important that you see your surgeon for these cases. So if you have an acute traumatic rotator cuff tear, so you have an injury and all of a sudden you can't move your arm, you get an MRI, rotator cuff is torn, that's a case where you should have surgery because the rotator cuff has the best chance of healing in the initial period after an acute tear. Again, that's different than a degenerative tear that happens over time. If you're having recurrent shoulder dislocations, that's the time you should have surgery as well, because again, every time you dislocate the shoulder, you can cause more damage. And if you're dislocating the shoulder more than once, there's pretty much 100% chance you've torn that labrum at that point. So we need to restabilize the shoulder, add some more stability to it. High-grade AC joint dislocations, the ones I was talking about that are collarbone sticking up all the way, almost about to pop through the skin. Those are another indication to have surgery. No need for non-operative management because it's not going to get better. And then there's patient preference. So there's certain conditions where patients will say, I don't want to try 6 weeks of therapy, and if that fails, then go to surgery afterwards. I got to get back to my job now, or I have this certain demand that I need to get the surgery right away. And that's something that a discussion you can have with them. You want to make sure that patient expectations are coming into play as well. There's a lot of athletes who put a high demand on their shoulder and they want to have surgery right away, and that's also reasonable. Let's talk about the surgery a little bit. I'm not going to go into detail about it, but just to give you an idea of what we're talking about. So I've said arthroscopic surgery a number of times here, but what does that really mean? So arthroscopic surgery is a minimally invasive surgery. It's all done through small centimeter poke holes with pencil-sized instruments that get put inside the shoulder. So you look in the top left picture here, that's an arthroscope in the back on the left side. That's the camera that we put inside the shoulder joint, and the picture on the bottom is the screen where we see everything that's inside the joint. So the camera is showing us what's inside the joint, and then we're putting other instruments inside to actually address the pathology that we need to address. So the benefits of arthroscopic surgery are that it's minimally invasive, not doing a big cut or opening up the shoulder anymore. You get a faster recovery because of that, less pain overall, and the morbidity is a lot less on the shoulder because less scar tissue forms. You're not going to have to open up as many structures. It's also nice that with the camera, you can look around the entire shoulder joint. So you can find any different pathologies or problems and address them all at the same time. You can do a rotator cuff repair, address it, take away the distal clavicle, also do a subacromial decompression like we talked about for the shoulder impingement. So you can really do a number of things at the same time arthroscopically, which is nice. Typically, this will be done under general anesthesia, so you're asleep for the procedure. You can also do regional nerve blocks with sedation as well, if that's a preference, but this is something the anesthesiologist would talk to you about. So I'm going to talk about 2 specific surgeries, the rotator cuff repair and the labrum, when they're almost finished up here. So the rotator cuff repair, again, we do this arthroscopically, so camera inside the joint. And you're seeing on this first picture here that there's a crescent-shaped tear in the cuff. So this red structure is a tendon that normally comes and attaches over here. So this would be a normal attachment. And here you have a crescent-shaped tear there. So what we're essentially doing, our goal is to bring this tissue back down and attach it onto the bone here. And the way we do that is we put these anchors in the bone. So this is called an anchor. And with these anchors, they have these sutures attached to them. Sutures are like stitches, and we put those stitches through the tendon, and we pull it back down onto the anchor to reduce the rotator cuff back to bone. So this is day surgery. You come and go the same day. You're in the hospital for about a half a day, and you're being in a sling for 4 to 6 weeks after surgery, depending on the severity of your tear. You're just typically doing physical therapy for about 4 to 6 months after. And that's the typical recovery period. This is an arthroscopic labrum repair. So this is, remember we talked about when your shoulder dislocating a bunch of times, and now you have a labrum tear, you need to get some stability back in the shoulder. Once again, this can be done arthroscopically. So you put the camera in the back of the shoulder, you find the part of the labrum that's torn, and you stitch it back onto the glenoid with anchors again. So here you see the picture. On the right side, we have the anchor coming in, being put onto the surface of the glenoid rim. And here you see some stitches that have stitched this labrum back on. So that's going to put this bumper back where it's supposed to be so the shoulder doesn't pop out of place. The other thing we do with this procedure is called the capsular plication. That's what you're seeing down here. What a capsular plication is, basically means that we're tightening up the joint capsule, that balloon around the shoulder. So when we dislocate your shoulder, I talked about your shoulder pops out forward, for instance, your joint capsule gets stretched because the bone is inside the joint capsule. So now we need to tighten that joint capsule back up so that it's not loose anymore. So that's what the capsular plication is. We pull that, with one of the sutures, we pull the capsule back up and we retension the entire shoulder. Again, sling for 6 weeks after surgery, physical therapy about 4 to 6 months afterwards. So when should you see a surgeon? So if you have any pain patterns that are consistent with the problems I described in this presentation, then that would be a good option to see a surgeon. Even if it just means you need to figure out whether you need to be treated non-operatively or need to be treated operatively, or if you need to be diagnosed with the right problem. If you have persistent shoulder pain that's persisted for several weeks despite the rest and anti-inflammatories, usually that means that you're failing the non-operative management, and it's a good time to see a surgeon as well. Any injury that results in a sudden loss of motion or sudden loss of strength in your shoulder, you should definitely see a surgeon, because that's concerning for an acute rotator cuff tear. And remember, I mentioned that the best chance of healing for those tears is if you repair them as soon as possible. Or if you have any shoulder pain in general that's restricting your daily activities, it's impacting your quality of life, and you want to be addressed, you should go see a surgeon. If you just have questions that you want to address about whether you need to see a physical therapist, or if your physical therapist refers you to see a surgeon, those are a great reason as well to see somebody. Lastly, if you dislocate your shoulder, you should see a surgeon, or if you fracture your shoulder, you should see a surgeon. And again, if you have any rotator cuff tear. So even if it's a small tear, it's important to be seen to ensure that you're not one of the candidates that need to have surgery versus somebody who can treat it non-operatively. But that's a general idea. And if you need to come in to see me personally, I work with Rothman Orthopaedics. This is our general phone line where you can call to make an appointment. You can also book online on the website on the right side there. We accept patients really quickly. We can see patients same day, and we accept most insurances as well. So if you have any of these problems with the shoulder that's concerning for you, but again, I'm a sports medicine surgeon who works on the entire body. So knee, hip, shoulder, elbow. If you have any problems that need to be seen, we're happy to take care of that. And I think now we're going to open up for the questions, and John's going to relay those for me.
Great. Thank you very much, Dr. Gohal. Thank you for that comprehensive discussion on shoulder pain management and all the options that you recommended. We do have a few questions here. First question is, why are steroid injections only recommended up to a max of 2 injections for rotator cuff tears? Is that twice in a lifetime or 2 times over a certain period of time?
That's a great question. I mean, in terms of there being a hard number on how many are recommended, that's a little bit gray. But the reason we don't like to do many cortisone injection for the rotator cuff is because some of the newer research that's come out in recent years has shown that cortisone injections actually decrease the healing potential of the rotator cuff. So let's say you're one of the people who ends up requiring surgery to fix your rotator cuff. It shows that after multiple cortisone injections, the tendon is less likely to heal back down to bone than someone who hasn't had any cortisone. So I personally will not do even more than 1 cortisone shot. And if it's somebody who knows that they're going to have surgery, I won't do any cortisone shots at all. So my typical practice will be, I'll get an MRI. If it's a small rotator cuff tear that we think we can treat it without surgery, then I'll offer a cortisone shot. If it's a large one, or they have an acute traumatic tear, or someone who definitely is going to end up needing surgery, then I'll just avoid the cortisone altogether, mainly for that healing potential.
Great, thank you. Zach has a question. Can a partial torn rotator cuff ever heal after tearing, or is surgery needed?
It's another great question. In partial rotator cuff, it depends on the amount of the tendon that's torn. A lot of the times they can heal if it's a partial tear less than 50%, but a lot of times they don't heal, but the symptoms can still go away. So we don't typically operate on rotator cuff tears if less than 50% of the width of the tendon is torn. We'll try to treat those non-operatively. And again, what really matters is clinically how you feel. We don't repeat the MRI or anything to check if the tendon healed. What we do is we examine you again. If your pain goes away, if your strength and your motion comes back, then we don't do surgery. If it's the opposite and your pain stays and your motion does not come back, then we start talking about surgery for those. If you have a width tear of greater than 50%, again, we'll typically try to treat this non-operatively, but these are typically ones that are more likely to require surgery in the end because they don't heal on their own.
Great, thank you. Scott has a question. Is surgery the only treatment for a full rotator cuff tear?
I mean, your options are non-operative treatment and operative treatment always. What I always emphasize to patients is, these are not life-threatening injuries, but they're quality of life-threatening injuries. If your rotator cuff is torn, there is no way to heal that rotator cuff, especially if it's a complete tear. But some people live with rotator cuff tears their whole life and it doesn't bother them. So if we can get you to a functional level where the rotator cuff is not bothering you, limiting your quality of life, then you can leave it alone. And the way we get you to that functional level is the physical therapy, the anti-inflammatories, and maybe 1 cortisone shot, like I mentioned. But majority of the time, if you're talking about healing that tendon and wanting to maximize your function with that shoulder, so really anyone who puts a decent amount of demand on their shoulder, then the surgery is going to be the best option for complete tears.
Great, thank you. I have another question. What restrictions are in place after surgery? So I don't know exactly what surgery they're speaking of, but
Mhm.
they're asking about the restrictions such as driving, lifting, etc. I'm assuming it's some sort of shoulder surgery.
Yeah, I mean, the majority of the arthroscopic shoulder surgeries have the same restriction. There are
Okay,
some slight variations. I mean, rotator cuffs are a little bit more restricted because the tendon has to heal back to bone. But in general, for the first 4 to 6 weeks, your arm's just going to be in a sling full time. We have you doing very gentle range of motion exercises like pendulums or swinging the arm a little bit. But other than that, you're really not using the arm at all. That means you can't drive, you can't do any overhead movement with the shoulder. What you can do is movements with the arm at the side. So you can still type with the arm in a sling. You can tie things or do small dexterity tasks. But other than that, you're really not using that arm that much for the first 6 weeks or 4, depending on the size of the tear. After you added the sling, we get you doing physical therapy to get your motion back and then strengthening afterwards. But for the beginning, really no pushing, pulling, or lifting with that arm.
thank you. Next question. Steroids have a reputation for making wounds worse. It's interesting to see that they are used for tears. Can you help make sense out of this for me?
Yeah, I mean, there's different types of steroids that you might be considering in that case. When you have systemic steroids for an autoimmune purpose, for instance, that's very different than a localized steroid injection. So if you're taking steroids that are going to suppress your immune system for an inflammatory condition or autoimmune condition, that's why you get higher rates of infection in wounds because your immune system's not functioning as well. These cortisone shots that we do locally into a joint don't have that same effect, and they typically don't have any effect on the incision. That being said, they do have a slight increase in infection rate if you do a surgery within the first 6 weeks after cortisone. So if anyone of my patients gets a cortisone shot and they end up needing surgery, it's always waiting a minimum of 6 weeks after the cortisone shot before we go back to do the surgery. Because the research has shown after 6 weeks, your infection risk goes back to normal. So that's an infection inside the joint versus an actual wound infection. But
Great.
it does eventually return back to normal.
Thank you for that clarification. Michael has a question. How long is cortisone likely to last?
So I kind of touched on that a little bit, but it really depends. It's hard to answer that as one general question because it depends on what we're doing the cortisone for. It depends on the specific patient and how their body reacts to it. For example, I'll talk to you about arthritis. If you have very mild grade 1 arthritis, we do a cortisone shot, you can get a year of relief, 2 years of relief. If you have advanced, final stage arthritis, bone on bone, you might only get a couple weeks or a couple months out of that cortisone injection. So that's an idea of depending on the severity of the problem. But even the same patient, or even this 2 patients with the same problem and the same severity might have different reactions to cortisone. Some people get 6 months, some people get 3. So it's actually very difficult to predict. The only predictive factor we have is the more severe your condition, usually the less duration of effect you'll have from the cortisone shot.
Okay, thank you. The next question is very general. I'm not actually sure, but let me read it to you. Maybe you can decipher this. Do you have a go-to place you like sending your patients to? And I'm assuming maybe this is for physical therapy, maybe, or I'm not actually sure if this individual would like to expand this. Or can you make sense of this a little better, Dr. Gohal?
I mean, they may be talking about physical therapy,
Okay,
which is fine. I mean, my most important feature for people in terms of physical therapy is that I want them to be committed to it. So I'll typically recommend, we know locations all over the city, all over Jersey City. And we'll say that you want to find a place that's either close to home or close to work, because that's going to be the easiest place to go and the place that you're most likely not to miss appointments. You're most likely to actually reach out to them. I know specific therapists in different areas that I work with closely who have specialized training in certain problems like ACLs or rotator cuffs, and I often prefer those patients, or those PTs, but it really depends on the specific patient. Like there's a lot of PTs who do running specific problems as well, gait analysis. So, I don't have one location where I send everybody. It's really kind of personalized. All my treatment plans are personalized to each patient.
and yes, it was for physical therapy. So thank you for answering that. And yes, as we've learned, physical therapists are very specifically trained for different parts of the body. So okay, thank you for that. Dana has a question. When can you start working out after a labrum tear?
A labrum tear. So after an arthroscopic labrum repair, so it's going to be the first 6 weeks in a sling where you're not doing much at all with that shoulder. after the first 6 weeks, you start the physical therapy, we're going to be just doing range of motion exercises. Usually for the 6 weeks after that, you're just doing range of motion. It's not usually until around the 3-month mark that you can actually start doing some strengthening exercises and working out. So normally it's around 3 months, it's going to be gentle strengthening. And then around 4 or 5 months, if we get back into the full strengthening aspect that you might have been doing before.
Great, thank you for that. Next question is from Sue. What is the failure rate of shoulder surgery?
So that really depends on what shoulder surgery we're talking about. And every procedure has a different failure rate. And it's kind of hard to give one general failure rate for that. So I would have to know what kind of procedure she's asking about, or he.
Okay, maybe they'll type some another question in here, or give me a little further. Next question is from Lisa. If you have trigger points in your shoulder, can you still lift weights above your shoulder?
Yeah, if you have trigger points, I mean, it would depend more specifically what she's referring to. If it's a nerve problem where she's having trigger point injections, you're still welcome to exercise and lift above the shoulder. Pretty much most problems, as long as you don't have a tear in the shoulder, you can do overhead activities. You can lift overhead. Impingement is one that might cause symptoms to be worse. But as long as you get that inflammation controlled and treated, then you're welcome to continue doing overhead activities. A lot of these problems, what I'll recommend is let pain be your guide. If you don't have a tear where we said you need surgery for, you pretty much can do most activities that don't cause pain. So if it's causing you pain, then you want to step back. That means you're aggravating that problem, you're making it worse. If you're able to do something without pain, then you're typically free to do that without a problem.
Okay, great. Next question. Can I get cortisone shot and physiotherapy same time if I have rotator cuff?
If you have rotator cuff tear, yes, you can. Again, I mentioned it depends on the tear pattern, how you tore it, how much function you have in your shoulder. If I think that you're not going to need surgery, we'll be able to treat this non-operatively, then I can offer you a cortisone shot and you can start the physical therapy 24 hours after. I typically say for 24 hours, take it easy, don't do too much with the shoulder. After that, you're welcome to just go back to full activity. So you can do physical therapy afterwards as well. But if you have a tear pattern that I think is going to require surgery, then I'll recommend that you stray away from the cortisone shot.
Okay, thank you. I have a question. Do they do robotic surgery on the shoulder as they do on the joints?
No, it's different. The robotic surgery on the joints is for navigation of what angle to make your cuts and specifically how to place your implants. Our form of robotic surgery essentially is the arthroscopic surgery. We are using instruments and tools that are all minimally invasive and put inside the shoulder joint, but it's not robotics because we're not using specific angled cuts and whatnot, which is the main purpose of the robotics and replacement and joint replacement surgery. So in short, no, but we are using technology and instruments that are, of similar integrity as those robots.
Okay, thank you. I do have a follow-up from Sue. Her question was about the failure rates of shoulder surgery. So she wants to know the failure rate of a rotator cuff surgery and can PRP repair rotator cuff tears?
So PRP cannot repair rotator cuff tears. I mean, it can reduce inflammation associated with the rotator cuff. And if you have a partial rotator cuff tear, a lot of times it can make your symptoms go away. If you have a complete full thickness rotator cuff tear, PRP will not heal that tear. In terms of failure rate, it is very, very wide range depending on the patient. So there's a few factors that influence failure rate. One is how long has your rotator cuff been torn for? Two is how much has that tendon degenerated. So over time, when the tendon is torn, you're not using that tendon, it tends to degenerate in what we call fatty degeneration. If you have a lot of fatty degeneration on your MRI, your risk of failure of the surgery goes up a lot. Next thing is if you have arthritis in the shoulder. If you have a lot of arthritis in the shoulder, again, your risk of a rotator cuff repair failing goes up. That's when we start talking about the shoulder replacements instead. And the acuity, so how long will this tear happen? Again, if you have an acute traumatic tear, the sooner we fix it, the better chance it has of healing. So all these factors play into it. So there's not really one number that you can say this is the failure rate. It depends on where in the spectrum you fall. But in general, tears you've had for a longer period with more fatty degeneration and larger size tears are higher risk with arthritis or at high risk for failure. Higher risk.
Right. Thank you for that clarification. Next question, I have neck and shoulder pain. Could it be related, or would it be a separate issue? There was no injury. It came on gradually and just has not subsided.
Yeah, absolutely. It could be related. Like I mentioned, that cervical radiculopathy is that aspect where you can have a nerve pinched in your neck that can contribute to pain in your shoulder. So it could definitely be something that's causing pain in both. If you have arthritis in your neck, it's going to cause pain in your neck, and it can also cause impingement of your nerves, which can cause referred shoulder pain. So, of course, I would need to examine the shoulder, take a look at the neck and the x-rays to see whether the problems are separate, because you can have a shoulder and neck problem at the same time that are separate. But a lot of the times the problem is all associated as one coming from the neck.
Okay, great. Thank you. And the final question has to do with the frozen shoulder, which I know you talked about in your lecture here. Is a frozen shoulder mostly treated with physical therapy? And how do you confirm a frozen shoulder is the cause of pain?
Yeah, so it's a great question. Frozen shoulder is mostly treated with physical therapy. A lot of times we'll use a cortisone injection as an adjunct to reduce that inflammation of that joint capsule and help the physical therapy be more effective. The way we diagnose frozen shoulders is a clinical exam. But based on your examination, when I see you in the office, if I find that you have decreased motion in all planes and you have a decreased glenohumeral arc, which is a specific arc of motion that I'll test here in the office, then I'll diagnose you with frozen shoulder. And again, frozen shoulder can be caused idiopathically or without any other problem, or it can be caused secondarily from another issue. So if I'm concerned that you may have had an injury that caused your frozen shoulder, then I'll get an MRI, not to confirm the frozen shoulder. The frozen shoulder is a clinical diagnosis, but to confirm that there's not another problem that's causing your frozen shoulder. And that would change the management as well. If you have a rotator cuff tear that caused your frozen shoulder, then we might talk about surgery. If you just have a frozen shoulder, then we treat it with physical therapy, plus or minus cortisone injections.
Great, thank you. I do have another question from Dominic. Will the shoulder replacement surgery ever be done arthroscopically in the future?
It's very unlikely, given the fact that we have to put in large implants. So if you look at those pictures that I showed you, we can't get those through 1 centimeter poke holes. So if you think about it, the size of that implant is maybe 3 or 4 centimeters, and we're able to do these shoulder replacements through 5 or 6 centimeter incision at this point. So just the size of the portal to get the implant in would be almost just as big as the incisions we use to actually do the surgery. So the problem with the arthroscopic surgery for shoulder replacement is that we have to remove bone, put in big implants. So that's why it's not done that way. However, we have to come up with more minimally invasive ways to do shoulder replacement. So before, we used to go to the front of the shoulder. We have to release your whole subscapularis tendon to get into the shoulder. Now there's subscapular sparing techniques where you can get into the shoulder with little smaller incisions, but in the end, it's still an open surgery. There's no arthroscopic surgery for rotator cuff repair. For shoulder replacement.
Great, thank you. And that is the end of our questions. I wanted to thank everyone who was able to join us this evening. For more information, or if you'd like to make an appointment with one of our physicians in the future, you can visit us online at rothmanny.com or call 888-636-7840. And just a reminder, we'll be sending out the recording of this lecture to all registrants within the next few days. So please be on the lookout for that in your email. Thank you, Dr. Gohal. What a great lecture today. And I wish everyone a good evening.
Thank you very much. And thanks all those for attending.
Thank you. Bye-bye.